Thank you. And the good news first, I will be very quick. I'm not a diabetologist, I'm a medical doctor. I worked in surgical research and I had a department at an institute that is having similar tasks as it has NICE and a similar task also to HAS in France. I will just quickly show you something about reimbursement of devices in Germany. What are the pathways? How we assess medical interventions, and these may include devices. And finally, I will just give you a brief overview of what has been done to assess CGM, real-time CGM. In Germany, we have no assessment of devices. This is something that is clearly different to France and also to the UK, because we never assess devices, we only assess methods. And these treatment methods may include one device, several devices in parallel or in sequence, and these devices can either be therapeutic or diagnostic. The other difference between Germany and the other European countries is that we have a borderline between ambulatory care and in-hospital care, because the idea is that everything is first introduced into the hospital sector. We have special pathways for medical aids and appliances. This may be relevant for some diabetic patients if you look at disabilities that can occur. And we also have special pathways for medical practice supplies, and there are also some other minor pathways how to introduce new devices into the reimbursement system. The system works like this, and this shows the third big difference between Germany and the other European countries. We have a system that is only under legal supervision of the Ministry of Health. We don't have the Ministry of Health inside all these bodies as an actor. They join the meetings, they sit at the table, but they don't make decisions. They only check whether everything is done according to law, but they don't say anything about endpoints and clinical relevance and all these other things. So the idea is that the stakeholders make the decisions themselves, and this is mainly the three bodies on the left-hand side, the payers, the statutory health insurance funds, and then, depending on what sector the decision is made on, either the German Hospital Federation or the Physicians Association. The Federal Joint Committee then makes a decision, and it may rely on IQWiG, which is the scientific arm, and we then do an assessment. So this is also something I think that is different to NICE. We have a separation between assessment and appraisal. We make the assessment, but we don't make decisions, because decisions are not made in Cologne, they are made in Berlin. What treatments are now being put under assessment? The assessment starts not when a new technology comes on the market. If a technology enters the German market, or the European market, I should say, the technology can be used inside hospital. It can be used, and it is being reimbursed by a special pathway, but the innovation is reimbursed unless the Federal Joint Committee makes a decision against it. And this is something which the sickness funds can apply for. They can say, we don't need this device in hospital, we don't need this treatment in hospital, we want to kick it out. On the other hand, no innovation can be introduced simply in the ambulatory care sector unless the Federal Joint Committee makes a decision supporting this. And of course, the Physicians Association always tries to put new interventions in the ambulatory care sector. So the innovations start at the hospital care sector, and then some of these go over to the ambulatory care sector, while others simply are being kicked out of the hospital sector. What IQWiG is doing is very similar to what NICE does. The only difference is that we don't look at costs. You may say Germany is a rich country and we don't need this, but I think this is more or less a political decision. Nobody in Germany wants to say to patients, you don't get this treatment because it is too costly. We don't have the quality. We have cost considerations in the drug sector. The evaluation of drugs is done on a cost effectiveness basis, or maybe based on a cost effectiveness basis. But when IQWiG is writing reports, standard reports, costs are not an issue. We look only at effectiveness. And I fully agree with you that you first have to define the question. If you get the question wrong, you are sunk. I fully agree. We have done this not so often, but I try to avoid it. So we have a external cooperation. We write a report plan. This is then discussed. We also invite patient representatives to discuss the relevance of different endpoints, let's say anxiety of hypoglycemia, and we then have a final report plan, and this report plan is then completed, and we start with information retrieval. We contact industry, but there's no application form because the start of the process is from Federal Joint Committee and IQWiG. So we may contact industry and ask them to send us their reports, but usually we start with a bibliographic search, and there may be interventions where we don't have any industry in the background, so we then have anyone to contact. Commenting is accepted from all public and stakeholders, and we then have a final report, a preliminary report with, again, some commenting phase, and we have a high level of transparency where every method detail is described. We have a special methods paper. The issue is that we try always to restrict ourselves only to patient-relevant endpoints. So we have our problems with HbA1c. We try to find endpoint studies, randomized control trials that look at mortality, morbidity, and quality of life. Not patient satisfaction, no lab values, no imaging results. We want to see that the patient himself, herself has an advantage. This is the example of CGM. You see that the timeline is quite long. This was related to some legal issues right at the start of the process. The application was handed in 2011, and we have now published the preliminary report. I don't want to show the report itself because all the details are difficult to explain in 10 minutes, and also we are in a process of compiling now the final report, and therefore I don't want to interfere with the preparation of this report, and we have a public hearing. We had a public hearing in October, so I think everyone has had a chance to submit arguments in favor or against our report. So the final report will be sent to GBA next month. We are already in the completing phase, and then the Federal Joint Committee has to make a decision, both in this case for ambulatory care sector and in-hospital sector. So I think I could explain that we have transparent pathways, and we are based on evidence, but in this case clinical, not cost efficiency evidence. We have the problem in Germany that most devices are not assessed at all after market entry. This is mainly the high-risk devices that are being used in hospital. We expect that the Federal Joint Committee will make a decision on CGM in late 2015 or maybe 2016. If you think that this process is too slow, we have a new law that now has passed the Chamber of States, Bundesrat, and they have agreed to this law, so I think it will come. And this means that the Federal Joint Committee is will have to complete all assessments, all decision making within 3 years, which would mean that we are having now, we would be left with 18 months to complete our reports, and they would then they would have their decision earlier as it currently is. And there's also another new issue that the Ministry of Health has proposed, and this is the routine assessment of all invasive high-risk devices. Don't ask me what high risk exactly means. This will be defined by the Ministry of Health, but it could involve also some type of diabetic devices, especially those that are implanted, artificial pancreas, and all these issues are at stake here. 10 minutes? Okay, thanks.